Hello, everyone. Christopher Brown here for Shockwave Medical as well as Murmur with a case of calcium modification in dissection. Our case today is a 70-year-old with hypertension and hyperlipidemia who presents for an angiogram due to angina despite 3-drug therapy. He has a preserved ejection fraction and upon initial angiography was found to have severe right coronary stenosis. You can see here a severe mid right coronary artery disease with pretty significant calcification. The operators for this case went ahead with balloon angioplasty of the mid-right, as well as more proximally. They were not getting good expansion near the AV groove pacing or the atrial pacing lead. However, that was not particularly appreciated at that moment. There was some difficulty delivering the non-compliant balloon, but ultimately they felt they were successful. They went ahead with advancement of a stent. However, they could not cross this severe lesion with the stent, and upon this angiography, were able to confirm that they, in fact, had a residual severe stenosis. They went ahead with larger non-compliant balloon inflations. However, this was not able to completely relieve the stenosis. It did, however, cause a relatively large dissection due to the high-pressure balloon inflation. At this point, we were called to help with this case. And we went ahead with repeat ultra high pressure balloon inflations with non-compliant balloons that were 1-to-1 sized. And you can see here we still have significant underexpansion. We then went ahead with Shockwave intravascular lithotripsy. And you can see here after just 10 pulses, we've completely relieved the calcified circumferential piece of calcium, and we have excellent expansion of our balloon. We went ahead and delivered 30 more pulses along the right coronary. And we then followed this with intravascular imaging. And what you'll be able to see here is there is a relatively long segment of circumferential calcium, which is well modified now with several fractures throughout. And in our cutout image here, you can see the large fracture in the very severe portion of calcium. This is in the area where the circumferential calcium was most difficult to expand. So we went ahead and placed drug-eluting stents using intravascular ultrasound guidance for sizing. And you can see here we have an excellent result. This is the final intravascular imaging where you'll be able to see a well-opposed, well-expanded stent. And we have excellent expansion, even in the area of the most severe calcification, which we're very happy about. And this is our final angiography. So what's important about this case is that it demonstrates some of the limitations of some of the other calcium modifying technologies, where the balloon-based therapy is dependent on hydrostatic force, and we went to the upper limits of what that balloon could tolerate. In addition, even if we had balloons that went to higher pressure, we would be putting the patient at risk for perforation or tearing of the artery because of the ultra-high hydrostatic force, such as, say, a 40 atmosphere inflation. The balloon-based therapies also don't selectively target the calcium, which is how they can lead to perforation or to other complications. While atherectomy would have selectively targeted the calcium, in this case there was a very large dissection, and thus it wouldn't be advisable to follow our NC balloon inflations with that dissection with atherectomy if you were able to avoid it. Intravascular lithotripsy was of excellent benefit here because it provided us with the ability to selectively target the calcium with minimal to no risk to perforation. We were able to modify any deep calcium that was present. It also didn't require ultra-high pressure and hydrostatic force, but it did selectively deliver 50 atmospheres of pressure to the calcium itself, which is ultimately what allowed us to relieve the circumferential calcified lesion. So in summary, Shockwave is a safe and effective method for modification of calcium in a dissection. Calcium can be limiting up front to your imaging, but with Shockwave, you can use proximal vessel sizing, lumen to lumen, and you can safely use your Shockwave because it's at low hydrostatic pressures of 4 atmospheres, and so your risk of complication is very low. Post-calcium modification confirmation is crucial to successful stent expansion and outcomes, and so we always recommend that after you perform lithotripsy or any other calcium modifying technique, you confirm that you have adequately treated the calcium so your stent can have the best outcome. Thank you.